I'm Norman Swan. Welcome to this programme on general practice nursing. Practice nursing presents some great opportunities and alternatives for primary health care. There are workforce shortages and they continue to cause concern. And many see nurses as critical to a sustainable workforce committed to high quality and safe health care. But there's been little acknowledgement of the skills nurses need to work in general practice and little formal education to support practice nursing. So tonight we're going to discuss the professional issues in practice nursing, their models of practice, training, education and indemnity. Now if you're watching on your computer, you can type your questions in directly to the studio. Just click on the Live Talk tab on the web page you're looking at. And that always means, of course, we can ask you questions. So here's one to get you going. Where are you located? Metropolitan, regional, rural or remote Australia? As usual, there are a number of useful resources available for you on the Rural Health Education Foundation's website, rhef.com.au. But now let's meet our panel. Dr. Brian Bowring has been a rural general practitioner for more than 24 years in Georgetown, Tasmania. That's a small industrial rural community with a 15-bed acute care hospital located about an hour north of Launceston. Welcome.
Thank you, Norman.
Brian has been chair of the GP North Rural Workforce Support in Tasmania and the Tasmanian representative on the Australian Rural Workforce Agencies Group. Julianne Badenoch is a registered nurse and midwife and has been a general practice nurse for 12 years and works in a rural general practice on the York Peninsula in South Australia. Welcome, Julianne.
Thank you, Norman.
Julianne has been a board director of the Australian Practice Nurses Association since 2004. Julie Porritt is a registered nurse and midwife with a Masters in Health Services Management. Welcome, Julie.
Thanks, Norman.
Julie has extensive experience in the health industry and hospital and primary care and has held the role of Principal Advisor for Nursing in general practice with the Australian General Practice Network. That's been for the past 7 years. And she's recently taken up a role as Programme Manager for Nursing in General Practice with General Practice New South Wales. And Lynn Walker is a registered nurse and midwife, and Lynn is also the subject coordinator for the postgraduate diploma in primary care nursing in the Department of General Practice at the University of Melbourne. Welcome, Lynn.
Thank you.
Lynn has worked in general practice for 10 years as a practice nurse and was president of the Australian Practice Nurses Association from 2001 to 2007 and is currently undertaking her Masters of Nursing Leadership. Well, welcome to you all.
Thank you.
How many nurses are we talking about in Australia, Julianne?
In Australia, we believe there are between 6,000 to 8,000, potentially more, throughout Australia. The AGPN certainly have done studies on that and have got much...
Julie?
Yes, excuse me. Just over 8,000 was our last count, and we're just doing a national census at the moment. And we know that 60% of practices employ one or more nurse.
And what's the pattern of practice? Is it mostly rural practice?
It's about 80% in rural and only about 40% in metro.
And have you looked at why the 40% don't have nurses?
Yes, we have. And we recently did some work through the network, and we asked practices that don't employ a nurse why they weren't. And we had just over 2,000 responses, and the most common reason, this is particularly for urban practices, not to employ a nurse is not the fact that they can't access the practice incentive program payment for employing a nurse.
So they want to, but the money's an issue?
Well, even though we know the business case is strong, even without the incentive payment, the fact that these practices can't get the payment acts as a disincentive for them because it's a mindset for them. Well, you know, we can't go down that track, we don't get that payment.
And then is it the same demographic pattern as general nursing, an ageing workforce? With all due respect to our present panel, of course.
Well, we're all ageing, Norman, as you would know.
Speak for yourself.
So I would say yes, it is. And that's probably something to say for the entire health workforce. I mean, the age of GPs is probably... you know, they're ageing as well. So, yes, in answer to your question.
And to what extent are nurses trained for practice nursing?
Well, there are two groups of nurses who work in general practice. The enrolled nurses, or Division 2 as they're now known in Victoria, have a shorter training course. would probably cover about 15% of the nursing workforce in general practice. The other 85% would be Division 1 nurses or registered nurses who have a 3-year training program as a basic.
That's what, but to what extent have they been specifically trained for the tasks? Because as doctors find out, they're not particularly well trained for general practice when they graduate, and you can't imagine that nurses are any different.
Well, up until probably the last few years, there's been very little postgraduate education for nurses to enter into general practice, so probably not as well trained as we'd like them to be. Certainly there are some courses around which some nurses are able to access, but there's a whole range of reasons why they don't do that. And most are hospital trained that go into general practice.
And how many postgraduate training schemes are there like yours?
I would say probably most of the larger universities would now offer some sort of training.
What sort of things do you teach?
We teach a variety.
How to stand up to general practitioners? Give them a hard time.
Well,
get off my back.
Strangely enough, the GPs don't send their nurses in for that one. So we tend to teach them things like chronic disease management, immunisation, taking pap tests, common chronic conditions, nursing leadership. They are some of the subjects that are on offer.
Do you find people get confused between practice nurses and nurse practitioners?
People get confused all the time, and nurses do as well, but certainly GPs get very confused. And there's a clear distinction between the two. Practice nurses are really nurses employed in a general practice. Nurse practitioners are nurses who have a minimum standard of education of a master's level and have a narrow but detailed knowledge of a certain area.
And what about competencies? Well, first of all, what are practice nurses out there doing, Julianne?
The roles vary, particularly between regional and rural centres. I always say they're Jacks and Jills of all trades and masters of many. We certainly have some practices focus more on clinical practices and tasks, and certainly increasingly the roles of the practice nurses are becoming more specialised and more of a focus towards chronic disease management, preventative health, and certainly data-based searching and looking for people that are underserviced and trying to find those and bring them in. I know that the AGPN have certainly done some recent studies on that, haven't you?
Yes, the Australian General Practice Network, in conjunction with in partnership with the Australian National University, were funded through the Australian Primary Healthcare Research Institute to look at a 3-year research project, looking at those factors that impact on the role of nurses in general practice. And through that study, we actually were able to identify that there were 6 key roles for nurses in general practice. So that patient carer role that Julianne was just talking about is a very important part of what nurses do, but it's only a small part of what nurses bring to the practice. So they also bring a problem-solving role. Nurses are very proactive at looking at and anticipating what might go wrong in a practice and putting systems in place to make sure things don't go wrong. They're organisers. They look after the quality systems, and certainly GPs in our study readily identified that they divested that quality role to their nurses because nurses do it better. Nurses have a big role in education, educating not only the patients but the whole practice team, medical students, GP registrars, nursing students, and even the GPs themselves. And nurses are these, what we called an agent of connectivity, so it's the nurses that actually link the team within the practice, but importantly link that practice with its community, so it's the nurse that actually builds the relationships with other health organisations within that community.
You've had a look at it as well, Brian.
We sort of had a look in our practice what tasks the nurses were actually doing, and the lower end tasks of simple clinical practices such as ECGs, pathology testing, point of care testing were very important for us, but the higher end and higher level roles that we've perhaps been talking about were some independence and autonomy is something that's quite difficult in general practice. The paradigm that I worked with when I first started practice was we've always had practice nurses, and they've always done these clinical tasks and have been there to help. In those days, there wasn't this emphasis on competencies and scope of practice. It was an arrangement between the GP and the nurses. Supervision was by the GP. Now, the situation is that supervisions via of nurses is by nurses, and they have to demonstrate to nurses that they have the competencies, and that seems to me quite logical. If we had a registrar in the practice, I wouldn't want them doing things that they didn't feel competent about. They'd have to demonstrate to me that they were competent in doing something. I would need to understand what my registrar could do. I think it's very important that as GPs we do work with the nurses and understand what their competencies are, and I think we will then be able to see greater roles for our nurses.
Let's get your questions come in, where you're located, and let's get the answers to that. In metropolitan, 36% of you, about 10% regional, over half of you in rural, and nobody from remote tonight. Usually have a few there, but that gives you an idea of who's at least on our watching us via the web. Let's ask the second question, and it'll just be interesting to know whether or not your practice employs practice nurses. Yes, no, you're thinking about it, never would. So give us your answers to those questions. We'll come back to you in a moment. Salary and wages, commenting on salary and wages being considerably less than state and state health nurses, state-employed health nurses. Lynn?
There's no question that the salary that's paid to practice nurses is well below the salary paid to those nurses working in acute and private sectors as well.
Why isn't that? Isn't there an award?
There is an award. It's quite complicated, and some of them are state awards. But certainly the awards and the industrial issues have probably been like a lot of other things where they're focused on the acute sector. So the awards that are current for nurses working in general practice are not as up to date, and it's a different system. It's a private system, so it's quite different.
A comment, Julianne, about enrolled nurses being put in RN nursing positions in practices, not necessarily being outside their comfort zone.
Yes, unfortunately that still is happening, and that's a big problem for those nurses, certainly with their they're working outside of their scope of practice. It's very important that GPs and practice managers understand that enrolled nurses must be supervised by a nurse. They cannot, due to legislation, cannot be supervised by a GP. They must be supervised by a registered nurse. That does vary a little between the states. It can be direct or indirect, but in certain states there certainly has to be protocols, etc. in place so that it's well understood. And
a question, Julie, is there an opportunity also from Kathy Powder for clinical nurse consultants in general practice, networking some supervision there that you might have in hospital?
There's certainly room for advanced roles for nurses in general practice, and many nurses are working at that level that we would describe as a clinical nurse consultant level in a hospital. I think there is certainly a career pathway for nurses in general practice, from the beginning practitioner through to more advanced roles, and then through to nurse practitioner if that's what nurses choose to do.
But you don't necessarily get paid more for doing it.
Yes, the issue is that there isn't a pay structure. And one of the elements that's different for nurses in general practice to perhaps other settings is because it is a business environment, nurses need to negotiate for a higher wage, and some have been very successful in doing that, but it's not something that is second nature to nurses, because we're used to being employed where there is a set award so that we don't have to negotiate, we can clearly see what that award is.
An online question, do you think current tertiary education programs for nurses, it's just disappeared from my screen, is adequate? The existing nursing courses?
No, probably not, because as we've seen, the role has expanded hugely in the past 5 to 10 years, and probably the education providers haven't really been able to keep up with offering what's required to do that role. And I guess there's not a lot of incentive for education providers to invest in education, given that the practice nursing workforce is quite small in comparison to other nursing specialties. So it's quite expensive to invest in those sorts of programs, and although there has been an increase in them, and certainly there's been a lot of education done through division networks and short courses, but at a postgraduate level there still needs to be quite a lot of work done for that.
Phoebe McCann from the Kanahuka Pharmacy asks, is there an industry database to search for nurses appropriate for GP clinic positions? Julie? Or Julianne,
sorry.
do you know?
I was just going to say the Australian Practice Nurses Association certainly has on its website, there is a dedicated area for where certainly businesses can put in an advertisement for a practice nurse, and there's certainly information on that website as well about general practice nursing, which is really useful.
Right, but there's not a list of nurses for hire.
Many of the divisions of general practice actually maintain databases excuse me, of nurses interested in working in general practice. And the other program that has just been introduced, because it was recognised there was a gap in providing an entry-level program for nurses that may be very experienced nurses in other sectors but not necessarily familiar with general practice. So there is now a national entry-level program for nurses orientation, clinical orientation program, for nurses interested in working in general practice.
Which is another question that's here online. How easy or common is it for a nurse from another area of practice, for example, the emergency department, to transition to practice nursing? Lynn?
The emergency department is probably one of the areas that would streamline more easily into general practice. And certainly most...
But if you've been a cardiac intensive care nurse, this might be a bit harder.
Well, it might have different challenges, but most of us came from the acute sector and we're all still alive and talking about it, so it can be done. I guess a lot depends on your goals and objectives and the type of practice that you want to, or that you will be employed in. And certainly if I were going for a job today in general practice, the questions I'd be asking as a potential employee would be around the role and what is it that's actually required for that practice.
Brian, tell me how money flows. How does the money work? What's the business model?
Yeah, certainly, Norman. There's so the majority of the work that nurses in our practice would do would be sort of procedural items which under the supervision of the GP, asking a nurse to do an ECG would attract a Medicare item. So a substantial amount of the monies that the nurses earned would be evaluating immunisation, wound dressings. All of these things now have Medicare item numbers. Some practices have nurses doing pap smears. That again attracts a Medicare item number. There's some intangibles that are...
You don't get rich on it.
Don't get rich on it.
Or the nurse.
There's some intangibles that are really hard to measure. How much do our nurses contribute financially to things like chronic disease care plans? How much do they contribute? Our practice is an industrial rural practice and sort of a mining processing area. How much do they contribute to the non-Medicare dollars that we earn by doing health surveillance medicals? And that's substantial. The bottom line is, though, that besides these income coming in, there's costs going out, and that varies from state to state. Part of the $77,000 cost deficit there is due to things like our practice is big enough that it cops payroll tax. But we would certainly say that money is well spent. We couldn't do without our nurses. They're indispensable to the way we practice. And we really need to be freeing up more of our time by having our nurses do more, and therefore we can do higher quality, higher end practice.
So you find your practice more enjoyable?
Oh, incredibly, and it's a team. It's not this vision that some GPs would have, where it's a competitive thing. You go in, and the nurses have been looking after a wound for several visits. we go in and we consult with the nurse. It's a team consultation about what the best method of managing for the next few visits is going to be. 9 times out of 10 it is they're going to suggest the dressing method, and we're going to sort of think, okay, fine, negotiate maybe slightly, but it's a team collaborative arrangement. I think that'd be shared by most members of the panel.
Can I say, Norman, I think that study Julia was referring to showed that only 21% of the role actually was clinical work. So that left a big chunk of what nurses do is not actually funded by the MBS. So 21%.
And are many GPs charging for the nurses' time in a non-reimbursable way? Do we know that?
I don't know that we collect any figures on that, but we certainly know anecdotally that that's not a common thing. Some practices do charge for the nursing services, but I was just interested in Brian's business modelling there, because certainly AGPN and other organisations have done the modelling around the business case for nurses, and generally that actually shows a profit, not a deficit. So it's just about, I guess, what's included in those figures. But I was just interested in that model, Brian, because I hadn't actually ever seen that.
But you can get on a treadmill, can't you? If what you're looking for from nurses is time with patients and their families and identifying problems and so on, being on fee-for-service, that task orientation could be a bit frustrating, could it not?
It's very frustrating. The general practice nurse population is a highly skilled population, and unfortunately they're a bit bound up in very much in a task orientated funding mechanism. But for the general practice nurse population out there, every encounter they have with their patient is another opportunity to help that patient and help it in a holistic way. It's the way we work, and the funding doesn't reward us in any way with that. So when Brian was talking about his funding model, what isn't counted there is the things that we're doing behind the scenes. And with a wound, with the attendance for a wound management, we're talking about the whole patient. We're working out what's happening at home. Do they need a medication review?
Can I say too, Norman, in that, I don't know whether you took this into consideration, Brian, but it's also the time that you're saving the GP as well.
Exactly.
So it's not only the income generated, but it's what the GP is able to do.
Yes, have you weighed it up against your revenue, increased revenue generation?
No, and that's quite difficult. And the other thing is, how could we, in the simplistic model, quantify the quality controls that the nurses bring? In accreditation, it's around the clinical standards. It's the nurses that are largely in control of that. And if we didn't have them, I mean, what value do you place on that? I wouldn't know how to measure that.
Well, I think that's an important point. We shouldn't just talk about the business model, because it is not only the business model. It's the fact, and the research tells us this, that having a nurse employed in general practice improves chronic disease care, improves the quality, reduces waiting times, all of those things.
And to what extent do GPs get it that nurses are relatively independent practitioners, and not to be supervised by doctors?
Autonomous practitioners?
Yes.
I think that there are many very successful GP practice nurse teams. A lot of whether they get it or not, some of that is tied up with the culture of the practice. So whether they are able to work as a team.
I think there's a whole body of work that divisions of general practice are doing and need to do more of, is sharing the very successful models that are out there and having people come from other areas even and talk in divisions. I've heard of some, quite a bit of division training, but it's really an important aspect of GPs learning from peers and nurses learning from peers.
And do practice managers get practice nurses? In other words, do they understand what's needed in terms of
I think
management?
Sometimes not. Certainly I've met some very switched on practice managers who knew exactly what their nurses were capable of, but I don't think that would be probably as widespread as we would like. Practice is a big business now. They are managed, they need to be managed very efficiently, and I would think knowing what all of your staff are able to do, what their strengths and weaknesses are, would be absolutely fundamental to any management of any practice. So I think there's probably some more work to do in that area as well.
Some more questions. Whilst there's a lot of material around for educating nurses, particularly on the internet, that's hard to access for remote nurses who often don't have doctors present all the time. Any suggestions how remote nurses who are working in general practice can access educational materials?
There's actually a lot of education available online that's free.
They're just claiming that when you're in the remote area, that's not as easy as you might think.
I guess it comes with challenges. And I know some education providers run distance courses as well, so if they can't access internet.
Julianne, you work in a rural area.
Well, certainly it's not an issue for us in our region. We certainly have very good IT access. But most of the organisations that do run these programs are able to, some way, if you contact them, they are able to actually get the programs out to you, whether that might be by disc or whatever it takes. Because especially through the APNA, if they ever want to ring in, we can certainly find ways to allow those nurses. The divisions are very, very supportive of that too.
It can be quite expensive, but I know that the model that rural remote GPs use is that often just leaving the area and going to a course, and there's several very good courses, but the Nurses Network runs an annual course, and the Competency Exhibition runs in 2 courses a year. You can just go and get all in one package.
So Lynn, how is competency scope of practice measured? I mean, how does an individual nurse know what his or her scope of practice actually is, what their competencies are, if we're talking about a relatively informal sector here?
Well, when you say informal sector, the scope of practice and competencies is not something new for nurses. It dates back to their very training. So it's an individual assessment which a nurse makes on their own practice. So it's not that hard for a nurse to determine their own competency, because there are certain questions you would ask yourself, and certainly the regulatory authorities have done a lot of work providing frameworks for decision making, so that there's a process to work out, am I competent to do this, yes or no. It's really not an issue for nurses. They are very clear usually about their own scopes of practice.
And there are specific competency standards for nurses that work in general practice. So it is relatively easy for a nurse then to have a look at those competency standards and see where they may.
And if a GP wants to look at them, where would they find them?
They're available on the Australian Nursing Federation website. And part of the package that was developed actually around those competency standards was a lot of information for GPs to actually assist them, and practice managers to actually understand the competency standards and how they might use them. I
must admit that in doing some reading around this program, I actually came across them, and I knew they were there, but it was the first time I'd actually formally had a look at them. I think this is the culture that needs to change within general practitioners' minds, that this is something that we do it informally in ourselves. We wouldn't do a procedure that we didn't feel competent to do. Nurses, it's a different situation, and we need to understand this need for competencies and scope of practice. I think it's vital that GPs start embracing this and looking into it and working with the nurses to understand how you can move forward.
Nurses are involved in quality and safety, and the medical benefits schedule doesn't reimburse for this. Isn't it valued by the practicing GPs?
It's certainly valued by the GPs. Without the quality, there's no accreditation. Without accreditation, there's certainly financial implications to the practice. I know that's not the universal model, but in the practices that have practice nurses, I would say it's virtually universal, that they are in charge of the clinical quality around sterilisation, procedures. That's their responsibility.
Julianne, is there a role for practice nurses to prescribe medication, for example, in chronic disease management?
There's certainly not a role for general practice nurses to prescribe medication. It is certainly becoming on the forefront of the role of nurse practitioners, but it's not within the scope of practice of general practice nurses.
But it's interesting though, Norman, in one of the things that actually changed the role for nurses in general practice in the UK was the fact that they instituted a course, a postgraduate program for all nurses so that they could actually prescribe. And there was a lot of quality systems put in place around that, and the world didn't come to an end, and patients were none the worse for wear. But for the nurse in general practice actually being able to see quite a number of presentations that they could treat quite adequately by prescribing medication certainly has been a big boom, and it's really changed the way that nurses are working.
I think that there's certainly a role for general practice nurses increasingly to be discussing their medications with their clients as a part of their holistic care, and that's just around quality use of medicine, which is certainly very important for all health professionals to be.
So Lynn, what's the most out there role you've seen for a practice nurse or practice nurses? I mean, it might be out there for Australia, but not so out there if you're living in another country where the role's been much more clearly defined for many years.
Well, there's certainly some very good examples of nurses running clinics, HIV medicine, looking after patients with HIV. Certainly there's lots of examples of well women, antenatal, nurses running antenatal clinics, looking after pregnant women.
Lifestyle.
Lots of lifestyle counselling. There's a very good program in Western Australia too, the street doctor program, where the nurses and sometimes a GP as well actually take a van out to the street and treat the people that are homeless and
there's
so
certainly
forth.
some outreach work nurses do, going into childcare centres and immunising and taking work out of the practice actually into the community. So there's quite a number of examples of that.
I think this is the end of the general practice nursing that needs to expand. Unless something dramatically changes with workforce, the workforce isn't going to be there. And who's going to suffer? It's the community who's going to suffer. You know, closing books in doctor surgery is not an answer. There's got to be another way of working cooperatively, so not substituting, but work is done differently. Nurses can fill a lot of that role.
Let's go to our first case study. Jackie is 50 years old. She smokes 30 cigarettes a day, and she's come to see the GP because she's got pain in her chest when she lifts heavy objects or goes upstairs. Her mother died of a heart attack. She's not had any palpitations, but she does have shortness of breath when she has the pain in her chest. What's the role of the practice nurse here, Brian?
Well, this may be sent in two ways. The person might not identify that they've got chest pain at the front desk. If they did in our practice, the reception staff would automatically escort that patient to a wheelchair or straight, if they were more able, to the practice nurse, who would then be doing observations, an ECG, and
so you've got protocols in your...
Protocols to what to do, connecting to the monitor, the defibrillator would be there, ready and waiting if needed, and then the doctor would be informed that the patient was there. The nurse might say, well, look, give me a couple of minutes, the ECG will be done, but can you come soon? They'd be assessed. If they were sitting in the waiting room and informed the doctor of this, there might be a little bit more history taking before handing them over to the practice nurse, but that'd be quite soon because you need the test to decide what's going on. But if...
And that's typical, that's an example of a non-reimbursable activity.
Non-reimbursable. Well, the ECG is done not by me while I'm doing something else. I can claim for that. But the troponin that's done is purely a cost to the practice. If this was a less acute situation, there could be some education role, and in the ideal setting, the education about the smoking and the risk factors that this person's got could well be done by the practice nurse if this is a more chronic setting.
I think it would definitely be done. And as I said previously, every encounter with a patient is another opportunity to be doing some lifestyle modification or just seeking a bit of background information. And certainly, while I'm doing an ECG on a patient, or any registered or enrolled nurse for that matter, we'll be seeking more information to see if there's some way that we can help them. And if this is not a crisis as such at this point in time, if we're doing this diagnostically, then you would be having a very good chat with them.
So let's say the GP has started them on, they've got stable angina and they just get put on statins and beta blockers or whatever else to control their symptoms. Do you have any ongoing role in your practice with a woman like this?
I would certainly be encouraging them to come back to the nurses for a chronic disease management role. So we would be talking at that first encounter about the value of setting up something along the lines of a general practice management plan and booking a further appointment for that.
Let's just take the answer to your previous question. Did your practice employ practice nurses? 81% of you say yes, 10% no, none of you are considering it, and 10% say you never would. I wonder why. We might ask that on another occasion. So I was just looking for the next question.
It's interesting, Norman, though, that those 10% that never would are watching this program. So they must have some interest in practice nursing.
Well, they might be practice nurses, and they want to. They might.
I think that's very encouraging.
Now, there's an interesting question here. Is there any evidence that nurses doing pap smears are any better at it than general practitioners? There's certainly evidence that nurse-taken blood pressure is more accurate than GP-taken blood pressure. Still not as accurate as home.
There certainly is some evidence, Norman, and every year the Victorian Cervical Screening Registry publishes a report on pap tests done in that state, and for the last, 3 or 4 years, it's clearly showed that the quality of the pap test with the endocervical component in those tests taken by nurses exceeds that of those taken by GPs. And the numbers of PAPs taken is increasing as well. So there is certainly some indication that that would be the case.
And it certainly is an area there is a significant unmet need, and I don't believe that the government's funding model for greater incentives for the more overdue the lady is in having a pap smear has particularly done a lot. So another paradigm, a way of addressing that problem is certainly needed, and I think offering pap smears with practice nurses may be something, because they're not doing it for some reason. Is it they don't want to do it with the doctor?
That same report also shows that the women who access nurses for that reason are usually the under-screened group that are difficult to engage with, and that it's just gone out of my head what I was going to say.
But speaking generally for general practitioners, I might be shouted down by the GPs, but I feel that a lot of GPs don't want to lose control of this very important role they've had. It's a way of relating very closely with that patient and the relationships they build up with that patient. They feel they'll lose if they hand over this test. But I think there's a way beyond that.
Women don't like men doing it to them, so...
Well, there's a percentage that prefer the male practitioner, the percentage that don't.
I think the thing that we have to remember, though, is that as with most of the services that nurses offer in general practice, it actually offers a choice to the patient. And it's not about telling patients they can or can't see a person. It's about offering them a choice. And if it's the right person that they see, it's the right patient for the right provider of the service at the right time.
I understand my understanding of the data is that you don't need to ask the question anymore about patient preference, or how patients are satisfied when they see the nurse, that overwhelmingly they are. But when they're offered that option, what are the data here? Julie, do you know? Have you looked at this when...
I don't know that we've looked at that data. Some practices may have done that.
There was certainly some research done a few years ago by for consumers, and the outcome of that was they were very acceptable to patients. Practice nurses were very acceptable to them, but they did point out that it needed to be a team and that they needed to be reassured that it wasn't that the doctors and the nurses were working together, that it wasn't one replacing the other, and that also patients still had access to the GP whenever they needed it. And clearly I think practice nurses, that's one thing they do actually very well, is triage patients so that those most in need of care actually get it when they need it.
I think
I think the other element that research showed is that patients identified there would be some things they would rather ask the nurse about.
My experience, whilst I'm not a credentialed pap smear provider any longer, I feel I've gone on to greener pastures.
But you broke your stick, did you, or what?
Something like that. I do know that the clients that came to see me for a pap smear very many of them actually came for another reason. So they were seeking, it wasn't the pap smear that brought them along.
It was their ticket of entry, as they say.
Yes, that's right. So there is certainly that role then.
Yeah,
Which GPs, this is the point, that GPs know, the conversation
and
that
it could be
starts.
about time, it could be about gender.
But separating it, I think, is even more important, because coming along with a problem they want to discuss and figuring the way they can get a double appointment or a longer appointment is to book a pap smear. So you do the well women's check, and you really then don't particularly do a good job of their problem that they really want to address, because
I think we have to
differentiate
here too, that nurses performing a lot of these roles are actually seeing, it's like for the PAP providers, it's the under-screened women and it's the normal person, like the normal woman. It's not, often they do have other problems, but we are targeted, our services are targeted to well women. So, you know, there's a lot of screening which happens in general practice, and there's going to be more screening as we move into that prevention mode. And there is absolutely no reason why nurses can't be involved in the screening practices rather than the diagnostic and ongoing management.
There's a lot of patient education needed here.
What we haven't touched on here are Indigenous patients, and the role of the practice nurse here when you've got a non-Indigenous, not an Aboriginal medical service. You've got a mainstream general practice with practice nurses. How does that play out with Indigenous patients, Julianne?
Well, as it is, our general practice does have a fairly high Indigenous clientele, and we do have one very, very fabulous practice nurse who certainly has a focus on the Indigenous clients, and they are increasingly coming into our fold, and it's been fabulous. There's a lot of preventative health messages.
Is this woman an Aboriginal person?
No, she isn't. No, she isn't. Married to a local cop, actually. Female, white. She is doing some great work. So I think this is a role that's certainly going forward.
And that may have something to do with the fact that we also know from the research that patients perceive that nurses would have more time for them than the GP, that, GP's busy and, better not waste the GP's time. But, a nurse might go a bit more slowly with me and give me time to actually ask the things I want to ask.
The APNA just recently undertook a trial consumer survey, and one of the things was that came out of it was that the consumer was very, very, very satisfied with practice nurses, and it was about the time and the easy access, etc. But in particular, the 18 to 35-year-olds were very satisfied, and that was we're not sure what that was about, but we think it was probably related to easy access and provision of information.
Now, for those of you who said you won't consider having one, or you don't have a practice nurse, the question is, if you don't have a practice nurse, what are the reasons? Cost, you unable to access PIP, space, availability, or you don't see much use for a practice nurse. So let's see what your reasons are, and while we're doing that, let's go to our next case study. Diane's a 46-year-old mother who works part-time. She's made an appointment to see her practice nurse for a regular pap smear. The practice nurse takes Diane's pap smear, but during the consult measures the blood pressure, and Diane's BP is 140 on 95. She's got a BMI of 28, so she's only slightly overweight. She has no history of hyperglycemia. However, her father does have type 2 diabetes. But the practice nurse feels Diane's at risk. What should and does the practice nurse do in this situation?
Well, I think it's probably a very common scenario, really. And I think what the practice nurse would do is have a consultation to address what the patient came in for, and have a general discussion about lifestyle issues and refer her back to the GP. She obviously needs some screening and addressing of a hypertension, so I would think she'd be sent back to the GP for workup for problems that have been identified.
And some surgeries would do a random sugar there and then, wouldn't they?
Yeah. I mean, I didn't hear, I must have been daydreaming. Did you say you do the diabetes risk assessment?
That's certainly something I would do.
Yeah.
Yes.
I think that's a great opportunity.
For me, that the lights are coming on straight away. I'm very much an practice nurse, and the lights are coming on that she scores 7 for being 46 years of age and having a family history, so that immediately puts her at risk. So I would certainly be asking her to do the Oz risk tool herself, and suggesting or ensuring that she comes back to see her GP and have a fasting blood glucose level at some point. I'd be touching base about, diabetes, etc., finding out what her knowledge base is. All of this can be done very, very quickly in that one consult.
But I mean, it's interesting, there'd be very few hospital-based nurses who would even know about the OSD risk tool. I mean, this is really a tool for general practice. And how do nurses learn about that sort of thing?
Well, I think that's where the new orientation program comes in, because nurses can nurse in any environment. They're delivering nursing care. That doesn't change. But what's different about general practice is it's a different environment to work in. So there are those things about Medicare and the various EPC items and things like that that are really, only pertinent to general practice.
Yeah, and there's probably 1,000,001 examples we could quote of patients going into hospital and coming out with problems that weren't addressed when they were there because medical staff, for a variety of reasons, and nursing staff weren't able to to touch on. So I think that's just a symptom of our system, and the fact that these patients can access that sort of care in general practice is very valuable for the community.
But of course, this woman doesn't qualify for an EPC item.
But not at this point, but she's highly likely to, and then that's the key role for a practice nurse, contributing to the ensuring that this person has the level of care they need over the 12 months to make sure they're having optimal diabetic care.
But I think, though, that you touch on an important point there, Norman. I think the models of funding for general practice need to change.
Absolutely.
If general practice teams are going to be able to deliver the best care, as Lynn said, the best person.
So salaried care,
Yes.
delinked from piece rates.
Yeah, that's exactly right. So a blended payment system.
Yeah, and another important point is actually the capacity of the nurses to actually pick up problems. So there's a huge opportunity for nurses to actually to pick up issues which can then be addressed, and that's not funded either.
Do you conduct teaching sessions in your practice for mutual learning or things like that?
We have regular clinical meetings where practice issues are discussed. The nurses are welcome to come to, we have registrars welcome to come to those meetings, and depending on the topic they do. But I wouldn't say that we'd have meetings that were nurse orientated, have a section that was specifically nurse orientated. Something to think about, Norman.
One of the things that we found from the Australian General Practice Nurse study was that those practices where there is good teamwork and there is autonomy for the nurses, they're the practices that actually have regular team meetings and clinical meetings between the GPs and the nurses and their allied health professionals.
Yep.
It's certainly part of the third standards of general practice that there be clinical meetings attended by all health professionals providing clinical care. And yes, as you said, there's certainly
On reflection, I've probably undersold ourselves a little bit. Our clinical meetings probably are attended.
Good.
So it's
So
good.
there you go.
It's getting better all the time, Brian.
Yeah.
Oh, look,
You'll remember eventually.
I'm digging myself out of the hole.
Our next case study is this general practice, which has no female GP, has employed a nurse who has undergone education in the area of women's and sexual health. The nurse has established a well-women's clinic and marketed it to women in her area who have been identified as being under-screened. The practice has agreed on a policy for the patients that the nurse will target cervical cancer screening, pathways for referral, and billing of patients. And she will have her own appointment system, use the MBS item numbers, and there may be an out-of-pocket expense in line with the practice policy for some patients. Is that what's happening out there in the real world then?
Yes, it is.
increasingly.
Yeah. And I think it's part of the process that we need to go through is to educate patients that sometimes there will be a cost, and that seeing the nurse for a service that is comparable to the GP is actually not a cheaper service. It is is as good as, and therefore will cost as much money as what it is to see the GP.
Just before we go on with that, there's a comment here from Anne Callum from GP Partners in Queensland. This 46-year-old lady should qualify for the 45 to 49-year-old health check Medicare item number, should she not?
Yes, but she still needs to see the GP, is my
Right,
understanding.
the nurse
Yeah,
doesn't.
that was the
Get it.
differential.
Yeah.
Yep.
So what's the journey that a practice has got to take to get to this point with this practice here, with this Well Women's Clinic, Julianne?
Well, certainly it needs to be a team effort, absolutely a team effort. There needs to be protocols, as stated here, in place before we even get started. The consensus needs to be that this is where we'd want to go and this is how we're going to do it. The nurse certainly needs to be credentialed and confident in her role, and that she has a great relationship with everybody in the team, including her practice manager and all the other nurses. And the funding doesn't necessarily reflect the work that will be done along the way. But it is about choice. It gives more choice.
And is there a professional indemnity issue here?
No, I don't think so.
It's just important for the practice to actually let their medical insurer know that the nurse would be doing that. But there's otherwise not an implication.
I think it's, you could probably summarise it by saying that whenever you introduce a service like this into a practice, there needs to be a general agreement and culture within the practice that it's going to work in a certain way. There will be a team, this is how it's going to work. We're all very clear about our roles and responsibilities, and there's a clear referral pathway, there's a clear billing procedure, the receptionists know what the billing procedure is, so that everybody's absolutely crystal clear on how the system works.
Comment here from Leanne Kotz, Munta Medical Centre. I'm a practice nurse and believe we are a vital part of the GP team and should be paid the equivalent to hospital nurses and not a much lower award rate. Just feeding back into our earlier discussion.
There's no reason why not. They're just as competent. It's just the historical evolution.
Tomorrow when you get back to Tasmania...
I'll have a revolt on my hands, won't I?
Yes, and our nurses in the practice that we work at certainly are. Thank you, Leanne.
I'd say that, look, I'm sure it'd be shouted down. It's not the only attraction, but the hours of work probably are why a lot of nurses opt out of the higher paying hospital work for a more 9 to 5 type regular
Actually, we've
practice.
done a bit of work around that, and there are a number of reasons. The family-friendly, so-called family-friendly hours are only one, really.
Yep.
There are elements around the patient continuity, so nurses love that as well, just like GPs do, and it's certainly something they don't get in the acute sector. But it's also the scope of practice, the variability of the role.
The
holistic care that nurses really need.
Just that takes the question that we had earlier, and then we'll come back to the point. If you don't have a practice nurse, what are the reasons? That's what we asked you, and 100% said cost. We have to say that the sample was low, given that almost all of you actually did have practice nurses, but those of you who answered, it was the cost. Let me just go to the next question, because we're getting towards the end of the programme, and this is to the nurses watching. Are you currently working to the full extent of your scope of practice? Yes or no? It would be interesting to actually hear that question. I interrupted Gillian. What were you going to say?
I was going to say on the subject of payment is that if we think about how the corporate world works, there's incentives for people to work to capacity, to have throughput. We don't seem to have that same culture in general practice, and I would suggest that when Brian goes back to his practice tomorrow, maybe he might like to think about paying his nurses a percentage of the PIP income for the outcomes payments. Like, I don't really understand why...
But isn't that that's fine, it gives people payment and it goes along with the system at the moment. But the reality is, don't we actually want to get better health outcomes out of all this? And that you're just playing the fee-for-service game?
Well, the reality is that's how we work, and if we're talking about reward and incentivising and getting nurses to stay in general practice, which is probably becoming another problem, is the retention, it may be, if they're actually paid more, that the attraction will be higher.
I think certainly the pay-for-performance system that they have in the UK, where it doesn't matter who does the work, the income comes to the practice, may be something that we need to look at in Australia to better reward the teams.
Certainly the Health Reform Commission has made statements along that regard, and I think really that needs, if general practice nursing is to really go forward, that's something that really needs to be addressed, this model of payment.
Julie Buist from the Wuchopperen and Outreach Health Service asks, do you see a role for child health nursing in general practice extending beyond providing immunisations and funded by Medicare?
There's no reason why any primary care nurse couldn't be situated in general practice, whether it be a public health or child health nurse, immunisation nurse, occupational health and safety. I mean, I don't really understand. The only barrier I think we have at this point is how they're funded. So the actual working together as part of the team and looking after the community and public health, I think it's a great idea.
Do we know about churn? What sort of turnover there are of general practice nurses?
We don't collect statistics nationally about the level of turnover. We do know anecdotally that nurses have come into general practice and left, and sometimes that's been because they haven't been supported. And another reason why we've introduced an orientation program, a standard orientation program, so they do have some support to learn that role. But no, we don't have national figures to be able to do some work around that. I guess that's something that could be looked at.
Some of the work that we have seen through APNA is that the higher the turnover is often related to dissatisfaction, not being able to work at their full scope of practice.
How much do you have to learn about teamwork? Doctors are not very good at it usually.
Not generally. I think in rural practice it is, GPs are much more likely to be team orientated. They just have to be. They have to work with the ambulance officers, the paramedics, they have to work with the hospital staff, and so probably find it much more easy to do this much more easily. And I think at our practice that's certainly been the case to an extent, but you know, the ability to then go on and develop protocols that enable the higher scope of practice type of nursing to happen is the difficult step. And if we are going to make significant inroads into the primary care, this is where it's going to be. It's not going to be from general practice.
I think to have a good team, you actually have to work at it. It's a bit like a marriage, really, isn't it?
You have to want to work.
You have to want it to work, and you have to put time. You have to invest time and education and all those other things. And you know, I don't think general practice probably does that very well at all.
And I think it's something that has to change in the undergraduate programs too, for not just for doctors, for nurses and for allied health professionals, that there is more interprofessional learning and instruction around working as a team, because I think you do need to learn that skill. It isn't something that's second nature.
And how often is the practice nurse married to the GP? Do we actually know that figure?
We've got more important things to
Think
measure.
about.
Norman,
Except that it
need to know
could
about that.
affect the dynamic in the practice.
It does, and lots of
yes.
practice managers are actually the wives of GPs, and I don't think we should go
Yeah,
there.
okay.
I think this
we're on
is-
wobbly ground. You understand this?
I think this is an important concept, because I think practice management maybe has a few more years earlier development, but it's a developing art as well. Yeah. The practices now would have visiting dietitians, if they've got a good division of general practice, would probably have allied health services visiting. I mean, teams new.
Let's go to the answer to your question. Are you currently working to the full extent or scope of your practice? And the answer is, mostly no.
Well, isn't
I'm
that
not surprised.
interesting?
I'm not particularly surprised.
No.
An underutilised group of people.
Absolutely.
So here's quite a handy one for our last question from one of our online viewers. As an ambitious nurse, why would I go into general practice nursing? Okay,
Well,
here's your elevator pitch, as they say in America.
Well, it's actually a fabulous job, and it's a job which creates a lot of opportunities. It's a role that you can actually make very interesting, and you can do it exceptionally well. Patients love it, and there are lots of reasons to go into it. And just because it's not perfect the way it is doesn't mean we should stop trying and take the opportunities when they arise.
Julie?
Well, I think there is a new dimension in primary healthcare, and I think practice nurses are really at the forefront of that. We've had 7 years of really good groundwork and providing the framework that they need to really move on from here. And I think with the federal government initiatives around supporting more primary care, I think practice nurses just need to seize the day.
Julianne?
Oh, I love that, seize the day. It is the best job on earth. The only
Really?
job... Oh, absolutely. I'm very passionate about that. The only thing that I've ever done that was better was delivering a baby. It is a very highly skilled workforce out there just waiting to grab and run with the potential. There's no other job in nursing where you get to see the whole patient, you get to see your outcomes in the long term, you get to see the impact on the family and in the community. I'd certainly recommend any nurse out there worth their salt giving it a good look at.
Brian?
Well, observing from the outside, I think it is the long-term relationship that the practices nurses develop with the patients and their family. I think we've all talked about it, and I think that's key. The team, and working as a team.
Yeah,
Thank you all very much indeed. And let's hope that we have a better utilised practice nurse workforce the next time we do a programme on it here in the Rural Health Education Foundation. And I hope you've enjoyed this programme on general practice nursing. If you're interested in obtaining more information about the issues raised, there are a number of resources available on the Rural Health Education Foundation's website, rhef.com.au. Don't forget to complete and send in your evaluation forms and register for CBD points by completing the attendance sheet. I'm Norman Swan. From all of us, bye from now.